Imagine for a moment the incredibly intricate network of wires that controls, well, every single movement, every sensation in your body. It really is a marvel.
Absolutely astounding when you think about it.
Now imagine what happens when that network is suddenly, maybe severely damaged. The impact isn't just profound, it's potentially life-altering, affecting everything from a simple touch right through to the ability to move an arm or a leg.
Yeah, the consequences can be immense.
So today we're taking a deep dive into this fascinating and really complex world of adult peripheral nerve disorders. These aren't minor things. Our research calls them a gamut of problems. It can be anything from, say, common nerve entrapments like carpal tunnel syndrome.
Which many people have heard of.
Right, all the way to devastating injuries like those affecting the brachial plexus. That's that big nerve bundle in your shoulder area.
Exactly. A particularly nasty one.
Our mission today is to unpack the science behind these injuries. How they're classified, how doctors diagnose them, and then look at the cutting-edge treatments that are actually restoring function and critically alleviating pain.
It's a rapidly evolving field.
Think of this as your shortcut to understanding the incredible challenges and, frankly, the groundbreaking innovations in nerve repair. We'll try to do it without getting totally lost in the medical jargon.
We'll do our best.
You're going to hear some truly surprising facts, I think, and maybe have some aha moments about the body's resilience and the ingenuity of modern medicine. So let's unpack this. When we talk about peripheral nerve disorders, what exactly are we dealing with? The sources we looked at consistently highlight how much these problems affect a patient's function, their quality of life.
Indeed. And what's really fundamental here, the key starting point, is the underlying pathophysiology. Basically, how the nerve is actually damaged. That fact fundamentally defines everything else. The symptoms you might experience, the best treatment options. It all flows from the nature of the damage.
Right.
Early classification systems, the ones pioneered by Seddon and Sunderland, and then later refined by McKinnon, who added a 6th degree, they help us categorize these injuries along a very precise spectrum.
A spectrum, so it's not just broken or not broken.
Exactly. It ranges from something called neuropraxia, which is like a temporary conduction block. Think of it like a momentary electrical glitch that can resolve fairly quickly.
Okay, a temporary thing.
All the way to neurogenesis, which is a complete nerve transection. The nerve is just completely severed.
Wow. Okay, so it's not just if a nerve is injured, but really how it's injured and to what degree. Could you maybe walk us through that spectrum quickly? Why are those distinctions so critical?
Absolutely. So at one end, you've got neuropraxia. That's that temporary interruption in the signal, often because the myelin sheath, the insulation around the nerve, is damaged.
Ah, the insulation.
Right. But the crucial thing is the axon itself, the nerve fiber, isn't severed. So you don't get what's called Wallerian degeneration. The nerve fiber doesn't actually die back from the injury site.
So recovery is possible.
Yes, and often remarkably fast. It could be minutes, or it might take up to about 3 months, but it generally recovers fully.
Okay. And the other end of the spectrum?
That's your 5th degree injury, a complete transaction, often from a sharp cut, a trauma. And then McKinnon added the 6th degree, which is sort of a mixed picture, often called a neuroma in continuity. Meaning different parts of the same nerve cross-section might have different degrees of injury. Some bits might be okay, others completely scarred or severed. It makes repair very tricky.
That's a huge range of damage with clearly very different outcomes. It makes you wonder how doctors even begin to figure this out. What are the first steps in diagnosing these often really complex issues?
Well, a really meticulous preoperative assessment is absolutely essential. It has to be thorough.
Okay, what does that involve?
It starts with a detailed patient history, really understanding the mechanism of injury. Was it a high-velocity trauma, like a motorcycle accident causing a brachial plexus injury?
Right.
Or was it something more subtle, like a repetitive compression building up over time in the wrist? That distinction guides everything that follows.
And I imagine timing is absolutely critical here, isn't it? I saw that phrase, time is muscle.
It is paramount. That phrase, time is muscle, is spot on. If motor innervation, getting the nerve signal back to the muscle, isn't restored within about a year in adults, well, our research shows that meaningful muscle recovery becomes highly unlikely.
A year. That's a critical window.
It really is. Muscle tissue is incredibly time-sensitive. Then there's the physical examination. We use specific techniques, like lightly tapping along the nerve's path. That's looking for tinal sign.
That tingling sensation, right?
Exactly, that radiating tingling. And what's particularly insightful is that this sign can actually progress, move down the limb as a nerve regenerates. It shows you the advancing front of nerve fibers.
Wow, like a little progress report.
Kind of. And conversely, its absence in a specific area, especially up near the neck in plexus injuries, can be a very bad sign. It might point towards a root avulsion, the nerve being torn right off the spinal cord.
Which you said has a poor prognosis.
A very poor prognosis, yes. We also look for other key indicators, things like Horner syndrome, that's a combination of a constricted pupil, a droopy eyelid, and lack of sweating on one side of the face.
Okay.
Now, Horner's itself isn't specific only to nerve injury, but seeing it after trauma. It's a strong indicator of a severe C8 and T1 root avulsion, especially in those brachial plexus cases.
That's fascinating. It really is like the nerve is telling you its story through these physical signs. But I guess when the story gets complicated, that's when you need the high-tech diagnostic tools.
Precisely. Beyond just looking and feeling, we rely heavily on electrodiagnostic tests. Things like nerve conduction studies, NCS, and electromyography, EMG.
What do they tell you?
They can confirm if a nerve is being compressed. They can evaluate, say, the nard denervation, that's the nerve supply to the thumb muscles, and they can be really crucial in differentiating between problems starting centrally, like in the spine, versus peripherally out in the limb.
So ruling things in or out.
Exactly.
Yeah.
And for those really complex, closed brachial plexus injuries, doing these tests serially over time is vital. You might do an initial assessment around 2 months after the injury.
What are you looking for then?
You're looking for signs like fibrillations on the EMG, which indicate the axon itself is injured, or maybe, hopefully, you see nascent motor units, tiny early signs of recovery starting.
Hopeful signs.
Very hopeful signs. And imaging is key, too. An MRI or a CT myelogram can actually show if there's a root-level avulsion in brachial plexus injuries, which, again, massively impacts the prognosis and the treatment plan.
Right.
And sometimes even something simple like a chest x-ray showing rib fractures might rule out using the intercostal nerves, the nerves between the ribs, as potential donors for a nerve transfer. It's all part of building the complete picture.
Okay, so once you have that really clear picture of the injury, what are the goals of treatment? Is it just about fixing the nerve, or is it broader?
Oh, it's definitely broader. The goals are holistic, really. You're aiming for full restoration of both sensory and motor function whenever that's possible.
Okay.
But alongside that is the critical goal of alleviating pain, which can be debilitating, and reducing any symptoms from nerve compression.
Right, the pain aspect is huge.
Absolutely. So the choice of treatment then becomes this intricate balance. You're weighing patient factors, the specific type of injury, and, as we keep saying, crucially, the timing, how long it's been since the injury.
It sounds like there's maybe a traditional approach, the sort of go-to, and then some newer, perhaps more transformative techniques coming through. Where do surgeons typically start?
Yeah, you're right. For gaps in a nerve, places where the ends can't just be sewn back together without stretching them too much.
Yeah.
Well, historically, the gold standard has been autologous nerve grafts.
Autologous meaning from the patient themselves?
Exactly. You take a healthy sensory nerve, often from the leg like the sorrel nerve, and use it to bridge the gap in the injured nerve.
That sounds logical, but I imagine there are downsides.
There are. We call it donor site morbidity. You inevitably cause some sensory loss where you took the graft from. There's a risk of forming a painful neuroma there, and of course, scar formation. Plus, you only have so much spare nerve tissue you can harvest. The supply is limited.
Right, you can't just keep taking nerves. Okay, so this next development feels like it could be a real game changer. I've been reading about nerve transfers and also allografts. How do these compare? What makes them potentially so revolutionary?
These newer approaches are genuinely transformative, yeah.
Yep.
They offer some significant advantages. Let's take nerve transfers first.
Sure.
Here, you're essentially rerouting a healthy working nerve branch, usually one from a muscle that has some backup, some redundant function, and connecting it to the injured nerve that's lost its function.
So like bypassing the damage.
In a way, yes. But the key advantage is speed. They deliver those regenerating nerve fibers to the target muscle or skin more quickly. You're essentially converting a high proximal injury into a more distal one, closer to the target.
Ah, shortening the distance the nerve has to regrow.
Precisely. And this also allows surgeons to completely bypass the scarred area from the original injury, which can make the actual surgery technically much easier.
Makes sense.
Plus, unlike tendon transfers, which we might discuss later, nerve transfers typically don't require long periods of immobilization. That's huge for preventing joint stiffness. And sometimes they can restore functions where there just isn't a good tendon transfer option available, like turning the palm down, pronation.
That's incredible. It really is like rewiring the body's internal circuitry. Our research showed some really powerful examples, like using bits of the median and ulnar nerves to get elbow flexion back, or using the spinal accessory nerve, the one that lifts your shoulder.
It controls the trapezius muscle, yeah.
Right, using that to help the suprascapular nerve for shoulder function. But what are the challenges? It sounds incredibly intricate.
It is. While they're powerful, nerve transfers definitely take time for the recovery to show, months usually.
Mhm.
And the surgery itself, that intraneural dissection, separating out the right nerve fibers, it demands a really intricate knowledge of anatomy.
Precision work.
Absolutely. And another challenge the research points out is patient retraining. It can be quite difficult for therapists if they're not familiar with these very specific transfers, teaching the patient how to fire the new connection.
Right, learning a new way to make a muscle work. Okay, so nerve transfers are precise, effective, but demanding. What about allografts? These sound like they might be taking things even further.
Processed nerve allografts, things like the advanced nerve graft you might hear about, they are a fascinating alternative. These are actually donated human peripheral nerve tissues.
Donated, so not from the patient.
Yeah. Correct. They've been processed, decellularized, which means the cellular material, the stuff that would cause rejection, is removed, but the nerve's structural architecture, the scaffolding, is preserved.
Ah, so no immune rejection.
Minimal. That's the goal. And the major benefit here, you completely eliminate that donor site morbidity we talked about with autografts. No extra surgery site, no sensory loss from harvesting.
That's a huge step forward for the patient experience. What do the studies say about how well they actually work? Are they as good as the patient's own nerve?
Well, key findings from several studies, including work by Leckenby and Safa, show that allografts are definitely a viable treatment. For short nerve defects, the outcomes seem comparable to autografts.
Short defects. How short?
That's the key question. One study reported 73% meaningful motor recovery that's getting strength back to grade 3 or better on the standard scale for mixed and motor nerve repairs up to 70 millimeters, so 7 centimeters.
Okay, that's quite specific.
And 77% achieved meaningful sensory recovery, so pretty good results in that range.
But I remember our sources also highlighted a really critical detail here. The length and the diameter of the graft seem to matter a lot. You mentioned that 7-centimeter figure, but other research suggested a limit closer to 5 centimeters, especially for motor recovery.
Yes, that's a crucial point and an area of ongoing research and debate. The data strongly suggests that both graft length and graft diameter are negatively correlated with outcomes. Longer grafts, especially over that 5-centimeter mark, show a definite drop-off in meaningful motor recovery.
So if a patient has, say, a 6-centimeter gap, what then? Are surgeons forced back to an autograft with its downsides?
That's exactly the dilemma surgeons face. For those longer gaps, an autograft might still be considered the better option despite the morbidity, or they might pivot towards a nerve transfer strategy if possible. It really depends on the specifics.
And diameter matters too.
Yes, significantly. Increased graft diameter, particularly anything thicker than about 3 millimeters, was associated with poorer outcomes. The thinking is that the center of thicker grafts might not get enough blood supply initially, leading to central ischemia and scarring within the graft itself, hindering regeneration.
Fascinating. So the graft structure itself is key. But it's interesting you also mentioned allografts being used for pain.
Yes, that's another promising application. They're proving effective in treating chronic neuropathic pain. Studies show significant reductions in pain scores, less need for pain medication in many patients,
Wow.
and even restoring meaningful sensation in over half the cases studied for pain. They can even help resolve allodynia, that extreme sensitivity where even a light touch is painful.
So a really powerful tool, but like any tool, it has its specific sweet spot, its applications and limitations, especially around length and thickness. What about other options, things like nerve conduits? Where do they fit in?
Nerve conduits. These are basically tubes, either synthetic or made from something like a vein. They're generally limited to very short gaps, typically under 3 centimeters, and mainly used for purely sensory nerves, like in finger repairs.
Not for the bigger mixed nerves?
Generally not. For longer gaps or for mixed motor and sensory nerves, they often show poor outcomes compared to autografts or allografts. And they can have higher complication rates, like the tube getting pushed out or causing inflammation.
Okay. So beyond these direct nerve repair strategies, grafts, transfers, conduits, Are there other ways to restore function, maybe when direct nerve regeneration just isn't fully possible or hasn't worked?
Yes, absolutely. Tendon transfers are another major pillar of treatment. They're well-established, really time-tested procedures.
How do they work?
You detach the tendon of a working healthy muscle and reattach it somewhere else to take over the function of a paralyzed muscle.
Ah, rerouting the muscle's action.
Exactly. They often lead to quicker functional recovery, think weeks, maybe a couple of months, versus the many months needed for nerve transfers to work.
Yeah.
And therapists are generally very familiar with the rehab protocols.
But downsides.
Big ones. They can't restore sensation, obviously. The surgery often requires quite extensive dissection, which means more scarring.
Mm.
And they often involve periods of immobilization in a cast or splint, which can be a real problem if joints are already stiff.
Right.
Our sources even describe them as feeling conceptually more crude than nerve transfers, although they are undeniably effective for specific goals. And then for really devastating injuries, especially for trying to get hand function back after severe nerve avulsions, surgeons might use free muscle transplantation.
Transplanting a whole muscle.
Yes, moving a healthy muscle, usually from the leg like the gracilis, complete with its own artery, vein, and nerve, and hooking it all up in the arm to try and restore movement like finger flexion. It's complex, major surgery.
Wow. Okay, let's talk specifically about the brachial plexus for a moment. That sounds like a particularly tough area. Research mentions high-velocity trauma, like motorcycle accidents, causing something like 84% of these injuries. What makes them so incredibly difficult to treat?
Yeah, brachial plexus injuries are truly among the most devastating nerve injuries a person can sustain. The complexity comes from, well, just the sheer number of crucial nerves packed into that small space between the neck and shoulder.
The whole arm's wiring.
Essentially, yes. And the big fear, the most challenging aspect, is the potential for root avulsion. That's where the nerve roots are literally torn away from the spinal cord itself.
Ripped right out.
Correct. And that type of injury carries the absolute worst prognosis because there's no nerve stump attached to the spinal cord to regenerate from.
So, in terms of diagnosis, are there specific signs you look for preoperatively for these plexus injuries?
Yes. Beyond the general nerve assessment, clinicians are looking for those specific signs we mentioned earlier, like Horner syndrome, possibly indicating a C8T1 root avulsion, and that absentinal sign up in the neck area.
Yeah.
That's a really strong and unfortunately bad prognostic sign. It strongly suggests root avulsion, and critically, it means there probably aren't any healthy nerves within the plexus available to use as donors for reconstruction.
So, the local options for repair are gone. How do surgeons confirm this once they are actually in surgery? How do they map out the damage?
Yeah, the intraoperative diagnosis is critical. During the surgery itself, the surgeon carefully explores the plexus to confirm the exact level and the type of lesion for each nerve root or trunk.
What are they looking for?
Seeing a neuroma, a bundle of scarred nerve tissue at the proximal end near the spine, can actually be a good sign.
How so?
It suggests the root is still connected to the spinal cord, even if it's damaged. There's something there to potentially work with. Surgeons even sometimes monitor the patient's vital signs closely during the resection of these neuromas.
What?
In a lightly anesthetized patient, a sudden rise in heart rate or blood pressure when stimulating or cutting the neuroma can suggest there's still some functional connection back to the spinal cord. It's another piece of the puzzle.
That's incredible detective work using the body's own signals. But okay, once they're in there and they see the extent of the damage, maybe multiple roots are avulsed, how do they decide which nerves to actually use for the repair? Where do the donor nerves come from?
Donor selection is absolutely critical, and it's often a major challenge. The first choice, the preference, is always for intraplexus donors.
Meaning nerves from within the injured plexus itself?
Exactly. Nerves within the brachial plexus that somehow escaped severe injury, perhaps the C5 root or maybe parts of C7. These are preferred because they usually have a higher number of axons, more power, and patients generally find the re-education process, learning to use the transfer nerve, a bit easier and more intuitive.
But what if those aren't available, like in those avulsion cases?
Right. When intraplexus donors are unavailable or insufficient, surgeons have to look for extraplexus donors. These are nerves sourced from completely outside the brachial plexus.
Like what?
Common examples include the spinal accessory nerve, which we mentioned controls the trapezius.
The shoulder shrug muscle?
Yes, or intercostal nerves from between the ribs. Sometimes even the phrenic nerve, which controls breathing via the diaphragm, although using that has obvious implications.
Wow, sacrificing some breathing function.
Usually only one side, and careful patient selection is needed. In really severe cases, with multiple avulsions, surgeons might even use the contralateral C7 route.
From the other healthy arm.
Yes, from the uninjured side. It's a major undertaking, requiring long grafts to reach across, and the regeneration distance is significant, which makes the outcomes less predictable.
That's amazing. Are there other specialized graft techniques for these really bad cases?
Yes, another important technique, especially for those global plexus avulsions where almost everything is gone, is the vascularized ulnar nerve graft.
Vascularized, meaning it has its own blood supply.
Exactly. You harvest a section of the ulnar nerve from the forearm, but you take it along with its accompanying artery and vein, and then you plumb that blood supply back in near the repair site.
Why do that?
Studies show it can yield superior results, particularly when neurotizing the median nerve, using that contralateral C7 route we talked about. One study showed over 90% achieved protective sensation in the hand with the vascularized graft, compared to only about 50% with conventional non-vascularized grafts.
And faster regeneration, too.
Yes, a significantly faster rate of Tinel's sign advancement, suggesting quicker regeneration through the graft.
That really does sound like feats of surgical engineering. What about pain management in these extreme plexus cases? You mentioned deferentation pain. That sounds awful.
It often is. Deferentation pain, which results from the loss of normal sensory input from the limb, can be excruciating, intractable, and severely debilitating.
How do you manage that alongside the reconstruction?
Well, sometimes the nerve reconstruction itself can help alleviate the pain over time. But for patients who are experiencing overwhelming, truly debilitating pain before surgery, procedures like DREZ coagulation are often recommended.
DREZ.
Dorsal root entry zone. It's a neurosurgical procedure involving targeted coagulation, essentially creating tiny lesions right where the sensory nerve roots enter the spinal cord. The goal is to interrupt those abnormal pain signals.
And you do that before the nerve repair?
Often, yes. The idea is to get the debilitating pain under control first so the patient can actually engage with and tolerate the extensive physical rehabilitation required after the nerve reconstruction surgery. It allows them to focus on recovery.
That makes sense. Deal with the worst fire first. I also saw an intriguing detail in the research about gabapentin.
Ah, yes, that was an interesting observation. Some data suggested that patients who are on very high doses of gabapentin, a common nerve pain medication, for long periods before their surgery might potentially have poorer outcomes after nerve transfer or graft.
Poor recovery, why?
The speculation was maybe a possible suppressant effect on nerve regeneration itself, but it was more of an observation needing further investigation rather than a proven causal link. Definitely something that warrants more research.
Interesting potential interaction there. Okay, so after these incredibly complex surgeries, careful planning, intricate repairs, what does the long road to recovery actually look like for a patient? It must be intense.
It really is. Post-operative care is just as crucial as the surgery itself. It's a marathon, not a sprint.
What does it involve, typically?
Patients usually wear custom-made braces or splints for a period. These protect the delicate nerve repairs, but are often designed to still allow some joint motion. In fact, early controlled motion is generally encouraged to help the nerve glide and prevent adhesions.
Okay, not complete immobilization then.
Not usually for nerve transfers, though grafts might be protected longer. And then comes the intensive physical therapy. That's absolutely vital.
What's the focus there?
It covers a lot: managing scar tissue, controlling swelling or edema, managing any residual pain, and critically, retraining.
Retraining, you mean teaching the nerve its new job.
Exactly. Patients learn specific exercises, sometimes called induction exercises. They have to consciously think about activating the donor nerve's original function to make the newly reinnervated muscle work.
Can you give an example?
Sure. If intercostal nerves from the chest wall were transferred to restore elbow flexion, the patient might initially need to do a slight Valsalva maneuver, like gently bearing down, to make their bicep contract.
Wow.
Or if the contralateral C7 was used, they might need to consciously think about straightening their good elbow to help activate the muscles on the reconstructed side. It requires a lot of focus and practice.
That sounds mentally taxing as well as physical. How do clinicians track the progress? You mentioned tunnel sign moving.
Yes, tracking the advancing tunnel sign is one way. And we know that a faster rate of advancement. Remember that 6 or 7 centimole a month for vascularized grafts versus maybe 3 to 4 centimole a month for conventional grafts. That faster rate generally correlates with better final outcomes, especially in younger patients.
And EMG again.
Yes. EMG studies are used periodically too. They give a more objective measure of muscle reinnervation and recovery than just the tunnel sign or clinical strength testing, especially early on.
It sounds like an enormous commitment from everyone involved. What happens if that initial major reconstruction just doesn't achieve the desired results? Are there backup plans, second chances?
Absolutely.
Hmm.
It's not uncommon for outcomes to be incomplete after the primary surgery, especially with severe injuries. When that happens, secondary procedures can be used to augment function to try and get more improvement.
Like what kind of procedures?
These could include things like free muscle transplantation, that gracilis transfer we mentioned for hand reanimation if the initial nerve repairs didn't restore enough finger flexion,
Okay.
or more standard pedicled muscle and tendon transfers. Sometimes rotational osteotomies, cutting and rotating a bone like the humerus or radius, can improve limb positioning and function. And occasionally, joint fusions, like fusing the wrist, can provide a stable platform to improve hand function powered by the muscles that did recover.
So a whole toolkit of options even after the main event. Looking forward then, what does this all mean for the future? Given these incredible advancements we've discussed, what are the big challenges that still remain for nerve surgeons and what's exciting on the horizon?
Well, despite all the progress, surgeons definitely still face significant hurdles. A major one remains the lack of adequate proximal intraplexus donors in severe plexus injuries, just not enough good quality nerve nearby.
Right.
The finite supply of autologous nerve grafts is still a limitation. And just the sheer biology of it, the great distances that regenerating axons need to travel to reach their target muscles before those muscles essentially wither away beyond repair, that time limit is always looming.
So the race against time, what about future solutions? What's being explored?
Research is pushing into some really exciting areas. Things like exploring peripheral nerve graft implantation directly into the spinal cord for those avulsion injuries, using diced nerve fragments within vein conduit to try and boost regeneration signals. Continued development of nerve allografts, maybe finding better ways to manage the immune response or improve their performance over longer distances. Stem cell therapies are a huge area of interest. Could we regenerate functional nerve tissue or muscle tissue?
The holy grail almost.
Perhaps. And using various growth factors or biological agents to try and accelerate the speed of nerve regeneration. The general trend, though, seems to be moving towards more distal, targeted repairs, those interplexus mini-transfers, and direct neuritizations, trying to get nerve input closer to the target muscle faster to optimize outcomes within that critical time frame.
Continuously refining and pushing the boundaries.
Exactly. It's about making recovery faster, more complete, and fundamentally changing what's possible for patients with these often life-altering injuries.
Well, from those nuanced classifications of nerve injury right at the beginning, through the incredible precision of nerve transfers and the surprising capabilities of allografts, this deep dive really shows a field where science and, frankly, surgical artistry are coming together, and it's profoundly changing lives.
It really is.
It highlights just how critical that accurate diagnosis is, the meticulous planning, and just a deep, deep understanding of the body's incredibly intricate wiring.
And I think despite those complexities and the challenges that definitely still remain in nerve repair, these advancements we've talked about offer really incredible possibilities. Restoring function, yes, but also alleviating that debilitating pain and ultimately giving patients back a measure of control over their lives, improving their quality of life. That's the real goal.
So as we wrap up, maybe something to think about. When you consider that incredible journey a single nerve fiber has to make, maybe millimeters a day, to bring back feeling to a fingertip or movement to a muscle, what does that tell us about the sheer resilience of the human body? And maybe also about the ingenious, persistent lengths medicine goes to try and heal it? Definitely something to mull over until our next deep dive.